This chapter covers aphasia, memory loss, and cognitive syndromes caused by focal brain disease. In the following videos, you'll see some examples of Wernicke's aphasia caused by stroke, primary progressive aphasia and its variants, and amnesia caused by Alzheimer's disease.
Wernicke's aphasia is one of many different types of aphasia. It is most often caused by stroke. Its hallmark is an auditory comprehension deficit, a severe auditory comprehension deficit, so much so that patients have great difficulty understanding single words, sentences. They also have trouble monitoring their own verbal output, so they are not aware of the errors they're making in their own speech. So consequently, they speak very fast, very fluently, but the content of their speech is often devoid of true meaning. They may be using words, nonsense words, substitutions, semantic paraphasias, literal paraphasias, and this is opposed to Broca's type of patient who can convey meaning by their ability to use nouns and verbs. Wernicke's patient is the type that will go on, and you may not be able to understand much of what they say. The lesion associated with Wernicke's aphasia is typically in the left temporal lobe. It is a large, deep lesion affecting the underlying white matter. The deficits associated with Wernicke's aphasia are due primarily to damage in the middle temporal gyrus. Here we'll take a look at a patient with Wernicke's aphasia. He had a stroke about 10 years ago, and from this sample we'll see some of the hallmarks of the disorder using tests that are classically used from aphasia batteries. So we'll look at his naming deficit, auditory comprehension, repetition deficit, and spontaneous speech, which is very revealing of what a typical patient with Wernicke's aphasia sounds like.
How often do you play golf?
Well, I usually driving my office because I has a schedule so I can play golf or just visiting and talk to my friends and my wife.
So here we can see that a patient with Wernicke's aphasia understands the gist of a question. He knows that the question is about golf, he likes to play golf, he talks about golf, but he didn't understand the exact question. How often do you play golf? And he's unable to give an exact answer to that question. But you'll hear in his sentences content words that make sense given the context.
We had a friend of mine was playing with me, and that was a long ways. And he was a brother.
So you can also see, as he's talking, that he's substituting a related word for a target word, a semantic paraphasia. So for example, he initially is talking about a friend who plays golf and then calls him his brother. So it's in the ballpark, but it's not exactly who he's talking about.
What's that called?
You have a key.
No?
Pencil.
Pretty close.
Key.
What would you do with it? Show me what you would do with it. How do you use this?
Working pencil.
Yeah?
Working. You have a good working pencil. A pen, P-E-N, is better.
You got it. You got it. Terrific. You like that one better, huh?
Pencil.
All right. How about these? What do you call
Oh,
those?
you can have driving your picture, your camera,
Yeah.
activity.
Yeah. What do you call those? What's the name of this?
Pencil. Navy, picture,
Does anybody
movie.
else Does anybody else have some of these? Can you show me other ones
Pencils,
like this?
P-E-N-S.
Yeah, well, that was this one,
Pencils.
right?
Yeah.
Okay. How about these? What do you do with these? Show me
Theater.
what you do with those.
The theater. Pencils.
There you go. They look lovely on you.
Picture activities.
Okay, all right, good.
So, not surprisingly, one of the hallmarks of Wernicke's aphasia is a naming deficit. So, you'll see here, she's asking him to name some high-frequency items. She asks him to name a pen, glasses, and a key. So, for pen, the first one, she holds up the pen. He says, it's a key. A little later, pencil, so he's more in the ballpark, and then pen. So eventually he gets to the name. For the next one, glasses, he's not quite as on target. Driving, pictures, theater, pencils. He's perseverating on the last item that he saw. But then eventually he just takes the glasses and puts them on, showing us he knows what they are. And this is important because patients with Wernicke's aphasia are not losing the semantic knowledge in the way that a semantic dementia patient is. Semantic dementia patients lose amodal, semantic, conceptual knowledge about objects. And here he's lost the name for the object.
Glasses, pen, keys. Okay? Show me the pen.
Pen.
Yeah.
Pen. Movie picture, or you've got a pencil,
Okay.
and then you've theater,
Okay.
movie activity.
Show me the keys.
Right here.
Excellent. Great. Show me the glasses.
Right here.
Okay.
Driver.
Okay. And show me the pen.
Pen. This is
Okay.
a pen.
All right. Good.
Pencil.
All right. Thank you.
So here is a great demonstration of how profound the auditory comprehension deficit is in Wernicke's aphasia. This is an exam for auditory comprehension of single words. She asks him, show me the pen, show me the keys, show me the glasses. He's only able to point to the keys. Even after a repetition, he cannot demonstrate comprehension of single words.
I'm going to say some words and some phrases, and I want you to say them after me. All right? Say bed.
P-E-N-D. Penned.
Okay? Say bed.
Pent.
Bed.
Sten.
Okay? Say bed.
Pens. P-E-N-S.
Okay? What does that say?
Bed.
Excellent. Great. I want you to say that after me. Say bed. Bed.
Bed.
Excellent. Great. All right. Let's do another one. Okay. I want you to say pipe.
Pipe. Paper.
Pretty close.
Piper.
Pipe.
Paper.
Pipe.
Once more.
Pipe.
Pant.
Pretty close. Here it is written down. What does that say?
Pipe.
Excellent.
P-I-P-E.
Great.
Pipe.
Terrific. Okay. Okay. How about this one? What does that say?
Glasses.
Great.
Glasses.
You got it.
I shouldn't. Glasses.
There you go.
Glasses.
Great. Excellent. Sometimes reading it is a little bit better, a little bit easier. Good. Good. All right.
Patients with Wernicke's aphasia have difficulty with repetition tasks, even repetition of single syllable, single words. He or she asks him to repeat the word bed, to which he says penned. He has access to some of the phonological information about the word. He can give a few of the sounds, but he can't give you the full word. Importantly, when she writes the word bed, he is able to read it. Then she asks him to repeat it, and with that visual information, he's able to repeat the word. And this is important when communicating with someone who has Wernicke's aphasia. They'll have much more success understanding what you're saying, the content of the conversation, when they're able to read. They don't have to rely on only that auditory input.
Primary progressive aphasia, also known as PPA, is a clinical syndrome characterized by insidious onset and slowly progressive isolated language disorder. Other cognitive functions such as visual spatial functioning or memory functions are usually spared for the first few years of the disease. PPA is called by neurodegeneration of the areas of the brain involved in language functions. It is usually considered as a clinical manifestation of the frontotemporal dementia spectrum disorders, but in some cases can be caused by Alzheimer's disease. PPA was initially described as a unitary clinical syndrome, but the last few years of research have highlighted the existence of different clinical syndromes. These different clinical syndromes are caused by degeneration of different parts of the language network. The three main variants are non-fluent variant, the semantic variant, and the logopenic variant. Non-fluent PPA is characterized by decreased fluency because of motor speech deficits such as apraxia speech and dysarthria, and agrammatism in production and comprehension. Non-fluent PPA reminds of stroke-induced Broca's aphasia, but deficits can be much milder. This video shows a 57-year-old right-handed man who's been diagnosed with non-fluent PPA. His symptoms started a couple of years prior to this video. He's describing a picture of a scene, and you can notice his frank grammatical errors. He drops articles and pronouns. His speech is also slow, deliberate, and effortful, although he does not show frank apraxia speech.
There's a house close to the lake. Where's the sailboat on the lake? There's someone fishing on the pier. A boy is getting some water from the lake. He's, I think, is a shovel and bucket in close to the water. The other boy has flying a kite.
The video shows one of the two main symptoms of non-fluent variant PPA, which is agrammatism. In agrammatism in productions, patients have trouble producing correct sentences. They usually have more difficulties using grammatical words such as article, pronouns, and verbs. In this case, the patient is describing a picture, and you can hear that he makes mistakes by dropping articles and using the wrong verb. For instance, it says there is house next to the lake instead of there is a house. And also he says the boy has flying a kite instead of the boy is flying a kite. Motor speech errors are the second main symptom of PPA, and although he doesn't show frank errors, his speech is effortful, slow, and deliberate. This video shows a 55-year-old right-handed woman who's been diagnosed with non-fluent PPA. Her symptoms started about 3 years before this video.
Now take those three sounds and put them together and say that as long and as fast as you can. So it sounds like pataka, 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 pataka. I want you to say these words 5 times. First one is artillery.
Yeah. Artillery, 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 artillery.
Now catastrophe.
Yeah.
5 times.
Catastrophe, 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 catastrophe.
The video shows part of the motor speech evaluation illustrating the patient's apraxia speech. Apraxia speech is a disorder of motor speech planning. It is particularly evident when patients need to repeat multisyllabic words where the articulators move in the mouth. In this video, the patients make errors that are distortions of certain sounds, and also she has trouble sequencing different phonemes. For instance, when she's asked to repeat pataka, she's not able to reproduce the sounds in the correct order. Semantic variant PPA, also known as semantic dementia, is characterized by fluent speech and severe deficit in comprehending single words and in recognizing objects and known faces. These most anterior regions of the temporal lobes are not usually hit in isolation in stroke aphasia, so the semantic variant progressive aphasia presentation is very unique to neurodegenerative disorders, and it doesn't usually occur in stroke aphasia. This video shows a 56-year-old right-handed man who was diagnosed with semantic variant PPA or semantic dementia. His symptoms started about 5 years prior to this video.
This is a nice thing where I would be, right there on the water. That's a nice one. And of course, obviously, there are people who are just really seem to be enjoying it there, and they live there, at least temporarily. That probably is, they don't probably live there, but they just like to go there. And this guy and girl, they're having a lot of fun together.
This video shows a semantic variant or semantic dementia patient describing a picture. The video shows how semantic dementia patients' fluency is actually spared. The rate of speech is fast, motor speech is intact, grammar is intact. The only problem that the patient has in spontaneous speech is coming up with specific nouns and words that refer to objects that are depicted in the pictures. This video shows the main problem that semantic dementia or semantic variant patients have, which is trouble comprehending single words and trouble with knowledge of concepts.
Is it a tree? Is it a boat? Or is it a flower?
It's more of a tree than a flower, yeah.
How would you use it? How you would use it?
I don't use it.
Okay.
That's it.
That's fine.
I know.
That's fine, thank you.
The pink pearl, huh? What do they use this thing for? Because I don't never use this one. To erase things?
See, it's right
oh,
here.
I see. Okay. Oh, yeah.
Yes.
In the first part of the video, the patient is asked to point to a flower. He doesn't understand the word flower, and even when giving a multiple choice, he cannot decide that that very frequent object is called flower. In the second part of the video, he demonstrates the deficit that is very different from patients with stroke-based aphasia, which is a semantic memory deficit. This means that the patient have trouble recognizing objects, not only from their name, but also from all the other modalities of input. So he's shown an eraser, and he doesn't know what the eraser is. He doesn't know how to use it or what the object is. Touching it, looking at it, it doesn't help him. So it's not a single agnosia from one modality, but it's a semantic memory deficit from all the modalities of input. The logopenic variant is the variant of PPA that has been most recently described. It's characterized by an intermediate level of fluency with word-finding pauses and slow speech, but no agrammatism nor motor speech deficits. The other typical symptom of logopenic variant is a repetition deficit that is most severe for sentences. This video shows a 58-year-old right-handed woman who's been diagnosed with the logopenic variant of PPA. Her symptoms started 4 years prior to this video.
The father and mother are having a picnic while the sun is flying a kite, and Owen is playing in the lake. I kind of goofed that one up.
The video depicts the patient with logopenic variant describing a picture. It highlights how the level of fluency in patients with logopenic variant is intermediate between patients with semantic and non-fluent variant. The patient's speech is slow, but is not effortful, and she does not make motor speech errors. She also does not make grammatical errors. So from an ephesiology point of view, the patient is not non-fluent, but nevertheless, her speech production is very slow. She also makes occasional phonological errors, which is a typical feature of the logopenic variant. The video shows the same patient a year later doing a repetition task.
He is not coming back.
He is not coming back.
The pastry cook was elated.
What is it?
I'll say the whole thing again.
Okay.
The pastry cook was elated.
The belated.
The video highlights one of the main symptoms of logopenic variant PPA, which is difficulty repeating sentences, especially if their meaning is infrequent. In the video, you can see that she has no trouble repeating single words, although she does make some slight sound errors. The real difficulty appears when she's trying to repeat sentences. The sentences in which logopenic patients have more trouble are the ones with an infrequent meaning, such as the pastry cook was elated. In the early stages of the disease, sentences with frequent meanings, like he's not coming back, are usually not that difficult.
Patients with neurological conditions have taught us an enormous amount about the human memory systems. It's now very clear that there are multiple memory systems that are mediated by different parts of the brain, and deficits in these separate memory systems are known to be dissociable. For example, patients with basal ganglia lesions are oftentimes noted to have difficulty in learning new skills, and yet they may have no difficulty learning a new list of words. By and large, though, the types of memory impairments that are most striking in our clinical patients are those that we typically label as having an amnesia, and these are the sorts of patients who have problems with anterograde memory, the ability to take in new information and store it for later retrieval. Studies of neurodegenerative and lesion patients have taught us that the brain structures that are vital for this particular kind of memory system are in the medial temporal system. This is the hippocampus and surrounding neocortex. But patients with this kind of memory disorder are generally able to retrieve information that they had stored prior to the onset of their illness or lesion, so they're quite capable of remembering biographical information from earlier in their life and general facts and information and historical events.
That's fine.
Tell
me about your career. What did you do before you retired?
Well, I'd gone to law school, and then I practiced law for some years. And I think about 18 or 19 years, I became a trial court judge. And I retired from that after, I don't know how many years, about 30 years.
When did you retire?
Must have been in the year, I think it was 2002.
2002?
That seems about right. He was a substitute judge for a while. He would go to different counties and do work,
So in 2002, he's retired.
Okay, that sounds right.
What they have a very selective deficit in is taking on new information, storing it for later retrieval. During the clinical evaluation of a patient's memory functioning, there are a couple of things that are important to consider. First is that the assessment of memory should occur in multiple modalities, most typically measures of verbal memory as well as spatial or nonverbal memory. Verbal memory can take the form of remembering new lists of words or stories, whereas visual memory could involve recalling designs or faces or pictures. The other important dimension to consider is that any patient's performance on a memory test involves multiple stages. The first stage is when the patient has to process the information that's being presented to them. The second stage, of course, is when the patient consolidates the new information. That is, they store it for later retrieval. And then the final stage, of course, is the patient's ability to retrieve the information on demand. A very popular way of assessing a patient's verbal memory is with list learning. And as you'll see in this video, the patient with Alzheimer's-related amnesia is able to pay attention. He demonstrates good understanding of the information being presented to him. And in fact, his immediate recall of the list is, while not entirely normal, relatively good. He's given a list of 9 words, and by the 4th learning trial, demonstrates the ability to spontaneously recall 5 of the 9 words. All right, let's do it one more time. Okay. Same list, get as many of them as you can in any order. Tiger, cabbage, desk, rabbit, potato, bookcase, zebra, spinach, cabinet.
Tiger, cabbage, desk, spinach, cabinet. That's all I can think of.
All right, and now I want you to tell me all the words that were on that list I read to you several times before.
Cabinet, spinach, that's all I can remember.
Earlier, I read a list of words to you several times. I want you to tell me all the words that were on that list.
Can't remember a single one.
What's striking in the video is that even after a delay as short as 30 seconds, during which he's engaged in an alternate activity to prevent rehearsal of the list, he spontaneously retrieves only 2 of the words. And after an additional 15-minute delay, he remembers none of the words. Patients with more pronounced amnesia will oftentimes forget that a list of words had even been presented. Now, when a patient is unable to spontaneously retrieve much of the information after a delay, one of the clinical questions is, were they able to store the information but are not able to spontaneously retrieve it, or did they actually not learn the list very well to begin with? One good approach for evaluating this is to test their memory in a recognition format. And as you'll see with this particular patient, there's a underlying difficulty in clearly differentiating between words that had been on the list and words that potentially could have been on the list. So this poor performance in recognition memory reflects the problem this patient had in consolidating new information. Again, when you see a deficit in the consolidation of new information, this type of memory pattern is particularly suggestive of problems in the medial temporal system. Let's try this. I'm going to read more words to you. This time, after I read each one, say yes if it was from that list I gave you before. Say no if it wasn't. Here we go. Wallet.
No.
Bookcase.
No.
Carrot.
Yes.
Table.
Yeah.
Cabbage.
Yeah.
Lion.
No.
Seashell.
No.
Bracelet.
No.
Zebra.
Yes.
Potato.
Yes.
Horse.
No.
Matches.
No.
Camera.
No.
Bed.
No.
Fork.
No.
Broccoli.
No, I think yes.
Desk.
I believe yes.
Rabbit.
Yes.
Perfume.
No.
Dog.
Yes.
Window.
Yes.
Cabinet.
Yes.
Lettuce.
Yes.
Tiger.
Yes.
Chair.
I think so.
Spinach.
Yes.
Pencil.
I can't recall that.
All right.
Frontotemporal dementia, or FTD, represents a group of neurodegenerative conditions that often occur before the age of 65. Frontotemporal dementia, unlike Alzheimer's disease, begins in the front part of the brain and often attacks the frontal lobes, the temporal lobes, sometimes the basal ganglia, and sometimes simultaneously motor neurons as well. Demographic is that this is the commonest neurodegenerative condition under the age of 60, even more common than Alzheimer's disease, and is close in prevalence to Alzheimer's disease in people under the age of 65. There are three major clinical syndromes associated with FTD. One is a behavioral disorder called behavioral variant frontotemporal dementia. With this disorder, we tend to see abnormalities in behavior, social decorum, changes in personality is the first manifestation of the disease. Behavioral variant tends to hit the right side of the brain more than the left. There are two aphasia syndromes associated with frontotemporal dementia. One is a non-fluent aphasia, or a non-fluent variant that begins in the left frontal lobe. And there is a third disorder, semantic variant, which begins in the anterior temporal parts of the brain. Many cases of frontotemporal dementia with all of these subtypes are associated with Parkinsonism, because the disease also attacks the basal ganglia. And there's clearly a major subset of patients with frontotemporal dementia who also develop Lou Gehrig's disease, or ALS. So it's strongly linked to ALS as well. Pathologically, there are two major subtypes. The subtypes are defined by the type of molecule that aggregates in the frontal lobes and basal ganglia and temporal lobe. The major subtypes are associated with either tau aggregation or another protein, TDP-43. The TDP-43 variant is often associated with ALS as well. Additionally, there are two major genes that can be associated with frontotemporal dementia, and we think about 10% of cases are associated with autosomal dominant genes. One major gene is tau. This is associated with tau aggregates in the brain. The other major subtype, genetic subtype, is associated with progranulin mutations. And in these patients, we tend to see TDP-43 aggregates in the brain. Behavioral variant frontotemporal dementia is often an early age of onset disorder. Unlike Alzheimer's disease, where the bulk of the cases aggregate in the 70s, 80s, and 90s, the mean age of onset for the behavioral variant FTD is around 56. We see very young individuals who develop behavioral variant and have seen people in their 20s with this disorder. Similarly, you can develop this disease later in life, and we've seen individuals whose first manifestations of the illness begin in their 80s. We think that the behavioral variant is male predominant, and in some studies, twice as many men as women develop the disorder. The behavioral variant of frontotemporal dementia is a clinical syndrome associated with apathy, disinhibition, overeating, repetitive motor behaviors, or repetitive compulsive movements. Addictive behaviors are very common in the early stages of this disorder. Dramatic changes in personality that can sometimes include loss of sympathy and empathy for others. So many of these patients with this clinical syndrome are in the early stages of the disorder, misdiagnosed as having a psychiatric disturbance. Behavioral variant of frontotemporal dementia is often very insidious because the patients are rarely aware of their own changes. We often have to rely on their loved ones to give us information about when the disease began. It's very difficult to tell exactly when a person's personality changes or when they become pathologically apathetic or pathologically disinhibited. With that said, we know that once someone reaches the doctor's office and has a diagnosis of behavioral variant FTD, the disorder moves very quickly because we often see the development of atypical Parkinsonian syndromes with the behavioral variant FTD. Patients often fall, develop problems with swallowing, and die very quickly once this disorder has manifested itself. In one study performed here at UCSF across a number of sites, we found that the mean duration of illness was less than 4 years once a diagnosis had been made. There's a very fulminant form of the behavioral variant FTD where someone develops, in addition to the clinical behavioral disorder, a motor neuron disease or Lou Gehrig's ALS disorder. And those patients typically live less than 2 years. So this is a very rapid disorder where abnormalities in movement often lead to a premature death. At pathology, what we tend to see is anteriorly predominant atrophy, neuronal loss, and gliosis. We divide the FTD subtypes into those with abnormal aggregates of tau, others with abnormal aggregates of TDP-43, and a third rarer subtype, perhaps 5%, where the abnormal protein is called FUS, F-U-S. The TDP-43 and FUS subtypes of frontotemporal dementia are often associated with motor neuron or Lou Gehrig's disease, and the tau subtypes are often associated with atypical Parkinsonian syndromes such as PSP or cortical basal degeneration.
Keep them closed. I need you to keep them closed so that I can see if your hands move. Keep them closed. Close your eyes. Close your eyes.
Okay.
Keep them closed. Keep your eyes closed.
I get to flip off my kids, don't I?
You already did.
Like,
keep them closed, Dad.
Huh?
Yeah. Keep your eyes closed. Keep your arms like this and keep them closed.
Okay.
And keep your eyes closed.
Okay.
But don't let your hands. And keep your eyes closed.
How long, again, then when you think back from when you first saw something to getting the diagnosis, how long did that take?
Let's see.
About?
That took a good, I want to say it took us like 4 years.
4 years to get to that point.
Yeah.
And during all that time you're dealing with okay. He's not worried that you're crying.
You make me laugh, honey.
Okay.
If I say the letter B, you could say boy, baby, boat, Do you know what city you're in here? That's right.
And then he keeps his figures for his ants. And he records all of them and keeps them down by the day of the week and how many he killed. And then these stay here for quite a while. And then he also has all of his napkins that he likes to save, even if they're used or not.
Non-fluent variant frontotemporal dementia, also called non-fluent variant of PPA, has a mean age of onset in the mid-50s, but cases with a later onset have also been described. The main clinical symptoms of the non-fluent variant are agrammatism and effortful, halting speech. Single word comprehension and object recognition are spared in the non-fluent variant. Agrammatism is a main symptom of non-fluent variant. It consists in producing short sentences, often with errors that consist in dropping pronouns or articles. In comprehension, agrammatism manifests as a deficit comprehending complex sentences. Speech production is usually slow, halting, effortful, with speech sound errors compatible with apraxial speech or dysarthria. Many patients with a non-fluent variant start with a syndrome isolated to speech and language, but progress to develop a motor syndrome that is more generalized and can meet criteria for cortical basal syndrome or progressive supranuclear palsy. On neuroimaging, non-fluent variant is characterized by atrophy or hypometabolism in the posterior portions of the inferior frontal lobes on the left, often involving the anterior insula as well. Clinical pathological studies have shown that the non-fluent variant has been associated most often with the tauopathy, either cortical basal degeneration or progressive supranuclear palsy. However, cases with TDP-43 pathologies have also been shown. Another clinical presentation of frontotemporal dementia is semantic dementia, also called semantic variant of primary progressive aphasia. Patients with a semantic variant have a mean age of onset in the mid to early 50s, but cases with a later onset have also been described. The main clinical symptoms in semantic variant are a severe confrontation naming impairment and severe deficit in word comprehension. Patients also have difficulties with recognizing objects from all modalities of input, auditorily, tactile, or visual. Other typical clinical features of semantic variant are surface dyslexia and surface dysgraphia. Patients have trouble spelling and reading words with atypical spelling. In some cases of semantic variant, patients may have particular difficulty in recognizing famous faces or people known to them previously. Phonology and grammar are usually spared in the semantic variant. Patients are fluent, have good repetition, and good sentence comprehension skills. In semantic variant, as disease progresses, patients have greater deficits in language comprehension and object and face recognition. Patients can also develop behavioral symptoms similar to the behavioral variant of FTD, such as disinhibition, loss of empathy, and compulsions. However, unlike patients with the non-fluent variant, patients with the semantic variant rarely develop motor symptoms. On neuroimaging, semantic variant is associated with atrophy or hypometabolism in the anterior portions of the temporal lobes, usually more on the left, but in some cases more on the right. As disease progresses, atrophy can also involve the orbitofrontal and insular regions responsible for behavioral symptoms. Clinical pathological studies have shown that semantic variant is often associated with TDP-43 pathology. Of the three FTD clinical syndrome, semantic variant is the one that is most reliably associated with the TDP-43 pathology.
Alzheimer's disease is a disease of aging, and so the prevalence is about 1% in people in their early 60s, and then it roughly doubles every 5 years, and so the prevalence is incredibly high, around 35 or 40% by the time people are in their mid to late 80s. To be diagnosed with Alzheimer's disease, patients need to have progressive memory loss and can have progressive decline in other cognitive functions. And the decline has to be significant enough to meet criteria for dementia, so to interfere with day-to-day function. Now, these criteria were written in 1984, and since then we've learned a lot of things about the disease. First, we've learned that the disease starts in the brain probably a decade or longer before people meet criteria for dementia. Second, we've learned that patients who have Alzheimer's disease pathology in the brain don't necessarily present with memory loss. They might present with language problems or executive problems or visuospatial dysfunction. And third, there's been great progress in developing biological markers of the disease using imaging, MRI, PET imaging, as well as spinal fluid markers. So in 2010, the NIH and the Alzheimer's Association convened working groups whose goal was to update the criteria using everything that we've learned about the disease in the last 25 years. And the new proposed criteria will likely include criteria for preclinical diagnosis. So diagnosis of disease based on a biological marker even before the onset of symptoms or in patients with very mild symptoms. They will include patients who present with decline not in memory but potentially in other cognitive domains like language or visuospatial dysfunction. And they also will incorporate these imaging and spinal fluid markers in order to strengthen your level of certainty that a patient with a particular clinical syndrome really has underlying Alzheimer's disease in their brain. Most people divide the disease into early, middle, and late stage. In the early stages, patients have significant problems with memory or other cognitive functions, and that gives them trouble in performing what we call instrumental activities of daily living, things like paying the bills, performing their job if they're still employed, and they start to require some assistance with some of those things, but they're still independent with their own basic activities of daily living, dressing, bathing, feeding themselves. In the moderate stages, patients start to develop some difficulty even with performing these own basic self-care needs. And in the severe stages or the late stages of the disease, people require significant help basically to take care of themselves in all aspects. And in a typical patient, each of these stages lasts about 4 years. So the total disease duration is about 12 years. But that is highly variable from patient to patient, and things don't progress in a linear fashion. In other words, people might be stable for some time, then have a bad year and restabilize. It's very difficult to predict for an individual patient. Anatomically, neurodegeneration begins in the medial temporal lobe, in entorhinal cortex, and in hippocampus, and also in posterior parts of the brain, in the precuneus and posterior cingulate, and in the posterior temporoparietal cortex. And over time, the disease spreads and also may include the lateral parts of the frontal cortex. Pathologically, Alzheimer's disease is associated with two characteristic lesions. The first are florid-appearing extracellular plaques that are composed of a protein called beta amyloid, or A-beta. And the second pathologic feature are flame-shaped intracellular neurofibrillary tangles. And these are composed of hyperphosphorylated tau. And to make the pathologic diagnosis, you really need both lesions. So for years, there has been a major debate in the field about which of these lesions are more important, the amyloid plaques or the neurofibrillary tangles. And I think the field is coming to a consensus that probably both protein aggregates are very important for the disease. The genetic data really supports an important role for A-beta, whereas the clinical symptoms and the pattern of neurodegeneration more closely follows the tangles. And so people believe that A-beta may play an important initiating role, but that the creation or aggregation of tau aggregates is also necessary for people to develop the neurodegenerative syndrome. Until recently, we couldn't confirm the presence of plaques and tangles in the brain until the time of autopsy, but we have learned that the plaques and tangles leave a characteristic signature in the cerebrospinal fluid. So the plaques lead to a decrease in the total levels of the A-beta 1 to 42 polypeptide in the CSF, whereas the tangles lead to an increase in total levels and in levels of phosphorylated tau. And in the last few years, there have been a number of PET imaging tracers that have been developed that bind to the amyloid plaques and can be visualized using PET scans. So I think increasingly we're going to see these in vivo markers of pathology incorporated into clinical practice.
So tell me today's date.
Let's see, February 16th, 1961.
Now earlier though we were talking about the year and you gave me a different year. What year is it now?
2011, I think.
All right. And what season of the year is it right now?
I think we're about in March, aren't we? March or April.
Okay. And what season?
That would be spring, early spring.
Okay. And what's the day of the week?
Monday, I think.
Do you think that you have more memory problems than your peers?
I don't really know. I mean, I'm a graduate from, you know, from, God, can't believe me.
From Berkeley?
Yes.
Okay.
I just lost it. Yeah.
No problem. Okay, that's fine. Tell me about your mood. Sometimes do you feel like you a little bit sad or depressed?
No, other than what I expressed to you, I've never expressed that before. This is the first I've heard of it, but I believe it. I'm doing it to myself, or by not participating somehow, or I just, yeah, that is sad, very sad.
Okay, so on this page there are numbers and letters. So I'm going to want you to start at number 1 and draw a line from 1 to A, the first letter, and then to 2, the next number, and B, the next letter, and so on, going back and forth between numbers and letters in order.
Okay, 1A, 2B, 3C.
Perfect. So go ahead, this is just for practice. Start at number 1. Oops.
Oops.
So 1 to A, that was great. And then where do you go? What's the next? Go back to A.
A.
So from 1 to A, so go to A. And then what's the next number?
B.
So we're going back and forth between numbers and letters.
Okay.
So next number.
Okay.
So you went from 1 to A, and then the next number would be 2.
Yeah.
Great. And then where to next?
I guess it would be B.
Good. Very good.
If I can find it. Oh, here it is, B.
So good. So you went 1 to A, and you went from 2 to B.
Okay.
And where next?
Go. 3 to C. I already did that.
So where's 3? 3 is hiding. There it is.
3.
Yep. So you go from B to 3. And where do you go from 3?
3 to C.
Good.
for it to be, I guess.
Have you dropped activities or hobby that you used to enjoy or be proud of?
I would think so. Yeah, I just.
Could you ask your husband's opinion? Have you noticed that she's like a little bit depressed or like loss of drive or motivation? She doesn't want to do anything, just like sitting and.
Yeah, I think that's the question's well put. Yeah, I think she's not enthusiastic or has a strong opinion about a lot of things she used to. Used to love to garden and plant all kinds of new stuff and so forth. I think what she's telling us today is I'm hearing it very clearly, and I think it's a pretty true statement. And it has worried me. Like I'll say, what do you want for dinner tonight? Oh, I don't know.
I don't care.
That's right, I don't care.
So today we're going to talk about Lewy body dementia, also known as the dementia with Lewy bodies. This is one of the Parkinsonian dementias, along with Parkinson's disease with dementia. It is actually the second most common neurodegenerative disease in the elderly, making up about 20% of the neurodegenerative disorders. The onset of Lewy body dementia is usually in the mid-60s, but the range is from the mid-50s to the mid-80s. This is a slowly progressive illness, but it is slightly more precipitous than other neurodegenerative diseases such as Alzheimer's disease or even Parkinson's disease with dementia. In 2003, the International Consortium on Dementia with Lewy Bodies revised the guidelines for its diagnosis. Lewy body dementia is a clinical syndrome, and the diagnosis focus on the clinical symptoms. So the guidelines for the clinical diagnosis of dementia with Lewy bodies includes central, core, and suggestive features. In the central features, there are symptoms that fulfill the criteria for a dementia, but you will notice that although memory impairment is a feature of this illness, it need not be prominent at the onset. The core features are fluctuating or pronounced variation in attention and alertness. This is quite distressing to the patients, and often the caregivers or the patient themselves will tell you how they can do something at one moment and cannot do it the next. Patients with Lewy body dementia will often complain of visual hallucinations. These hallucinations usually consist of little people or animals such as cats. The hallucinations are well formed, but are not as distressing to these patients as in other illnesses. There is the spontaneous onset of Parkinsonism. Parkinsonism could include rigidity, bradykinesia, hypophonia, masked faces, slowed shuffling gait. Suggestive features include REM sleep behavior disorder, which consists of a lack of atonia during REM sleep. And so the patients will often act out their dreams. This is not distressing to the patient themselves, but their partners will often complain. They have severe neuroleptic sensitivity, and so their symptoms can be greatly exacerbated by dopamine antagonists. The progression of Lewy body dementia is slow, but unlike Alzheimer's disease and even Parkinson's disease with dementia, there is a more precipitous decline. The average survival for a patient with Lewy body dementia is 8 years. There are no known treatments to alter the disease progression. In the imaging of Lewy body dementia, we do not see a consistent pattern. Usually, there is more diffuse atrophy. Sometimes with metabolic imaging such as PET, we can see more focal abnormalities in the occipital lobe. The underlying pathology in Lewy body dementia is believed to be the Lewy body. These are inclusions that stain for alpha-synuclein, and they're found in the cortex as well as the brainstem. The other major illnesses that fall under the heading of synucleinopathies are Parkinson's disease and Parkinson's disease with dementia. In looking at the pathology of Lewy body dementia, one finds that there's considerable overlap with Alzheimer's disease. And so it is not infrequent that we will find Lewy body pathology in a patient with a diagnosis of Alzheimer's disease. As well, we will find Alzheimer's disease pathology in a patient diagnosed with Lewy body dementia. In this video, you will see a patient diagnosed with Lewy body dementia. He will explain the onset and progression of his illness. As he is speaking, notice his masked faces or hypomimia, his decreased blink rate, and listen for the hypophonia. And if you could just tell me what was the first thing you noticed when this first began? First of all, how many years ago was it that you first noticed this something?
Well, I don't know for sure, but I think probably 5 years ago, I had started to have memory problems. Couldn't remember people's names. I have 3 children, and I couldn't remember their names. It started to get more and more of the problems, and that I guess has lasted for several years. So it was a variety of things that would indicated to me that there was more going wrong here than just the memory problem. There was physical problems, vocal. My voice changed considerably.
This was fairly early on, or a few years after
the
memory.
Yeah. The whole sequence of analyzing this was about 5 years.
Okay.
I started to be more aware of other things going wrong, physical energy types of problems, arms, legs that don't quite function right.
Maybe a little bit slower than they used to?
Or scuffling in the feet, or just a wide variety of things that were not right.
Right. And you noticed your voice was getting lower, as you mentioned.
Yeah.
How many years ago do you think that started?
Probably 4 years.
4 years ago.
Yeah.
And did anybody ever comment on you having less of an expression, or not being as expressive as you used to be?
Yeah, the family was very disappointed in me. I was just deadpan, and I found out later that that's quite normal.
And maybe just stare at the camera for a few minutes. In this section, notice the bradykinesia in his finger and foot tapping. You will also notice cogwheel rigidity in the upper extremities. Can I get you to do this? As big as you can. And with your other hand. Okay. And can I get you to tap your foot? And make them as big as possible. Yeah, keep your heel on the ground, big taps. And the other leg.
ask you to relax your hand. In this part of the video, notice his stooped posture as well as his slow, shuffling gait with decreased arm swing. Also note his unblocked turn.
We're going to start hooking up 2 blocks. So you should actually talk with Marissa about how this should work.
Okay. You can come back towards her. Go back there. I don't know if you can tell that he's quite stooped.